internal medicine on how yoga can mitigate frailty. And so she's going to talk to us today about frailty in the primary care setting. Thank you so much for joining us.
Thank you for that introduction, Kate, and thanks for the invitation to speak today. So I'm just going to share my screen with you all. Okay, so I am going to talk a little bit about frailty in the primary care setting. This is where I spend most of my time clinically. So I work with internal medicine residents primarily, but I see patients for geriatric co-management in a primary care clinic at Brigham and Women's Hospital. So I'll be talking more generally about that and then some specific things related to mind-body exercise later on. So our objectives today will be to define frailty and identify it with a validated screening tool, and then understand management approaches to frailty. So I like to start with this slide. So this, you can imagine that this could be your patient, and either one of these photos could be a patient who's 75, has type 2 diabetes, hypertension, knee arthritis, osteopenia. So, we get sort of the list of comorbidities. They may be on similar medications, but we can know from seeing these two women that their healthcare outcomes and the way we might approach their care will be different. And so, people have thought about this for many years, and the model of frailty has been developed as a way to kind of describe the outcomes and explain why we might see different outcomes for these two different women. And so we'll be talking a little bit about why this is and some of the prevailing models. And also just to know, the reason we want to use a model like frailty in the medical care of these women is because we shouldn't treat people differently just because they appear differently. So this gives us a sort of scientific underpinning of why we would approach care differently. So the concept of frailty is an increased state of vulnerability to poor resolution of homeostasis after some sort of stressor event. So you can imagine here we have on the y-axis function, but you could also put cognition, disability, falls, institutionalization. So a number of adverse outcomes on that y-axis. And you can see here the what we would call quote unquote a robust older adult in the green line. If they had a minor illness, they would bounce back quickly and return to baseline. Whereas the frail person who's pictured in red here would have a larger setback, a longer recovery, and may not recover back to their prior baseline. There has been a lot of work done on some of the pathophysiology of why this occurs, and you can see this figure really takes things down to the cellular molecular level and then builds them up to sort of systems levels. But there are really sort of accumulated molecular and cellular damage as we get older, which leads to reduced reserve in different organ systems. And then we have modifiable factors like physical activity and nutrition that can lead to this sort of end state of frailty. So typically it's a long way to get there, but there's a lot of things we can do along the way to try to prevent it. And I think this audience probably knows that frailty predicts a number of different adverse outcomes like mortality, nursing home admission, hospitalization, disability, and falls. So the prevalence of frailty there's sort of a wide range of estimates depending on what model you use. So on average for community dwelling older adults, it's about 11%. But you can see as we get above age 80, the prevalence is thought to be as high as 25%, 26%. And then in nursing home residents, the prevalence is even higher. So over half of nursing home residents. And a lot of more recent estimates using different models are estimating these rates to be even higher. So there are two main overarching models that have been used to define frailty. So we have the frailty phenotype and also the deficit accumulation model. And I was just wondering if you, in the chat, if people feel comfortable, I would love to know if you have used a frailty screening tool or a diagnostic tool in your clinical practice and which one you've used. And I just try to focus on the outpatient clinic setting if you can. So just chat in, have you used a frailty screening instrument and what have you used? And I'm a little biased because I work in a geriatric consult clinic, so I do a lot of like very long frailty assessments, but I'd be interested to hear if you're seeing patients in a regular primary care clinic, or something similar, what you might be using. So you have the Frail scale, FRAIL, clinical frailty scale. Yeah, so those are some good ones for the primary care setting, and we'll be talking about some of the reasons for that. So I'm going to go through the first sort of model that was defined was the frailty phenotype model. This was defined by Linda Freed. It consists of 5 different characteristics that a frail older person might exhibit. So weight loss, self-reported exhaustion or fatigue, low energy expenditure, slow gait speed, and weak grip strength. So these are sort of the formal definitions of how you might assess each domain. I'm not going to go through these explicitly, but just so you know, so you have to have 3 or more of these to be considered frail, 1 to 2 is pre-frail, and then 0 is considered what's called robust. So if you think about primary care clinics, this stuff is kind of hard to get. Like most of us don't have a dynamometer to measure grip strength. A lot of us aren't routinely measuring walking speed in primary care clinics. So this is a really strong and well-validated model, but it requires some adaptations for primary care clinicians. This is the sort of underlying biology of the phenotype model. So just, the main takeaway here is that there's a vicious cycle that can develop and people can enter in at different points. So you might have people who, let's say they have chronic undernutrition because they're not able to access food appropriately. They might start losing muscle mass, and then their resting metabolic rate and walking speed go down, their activity goes down, their energy expenditure goes down, and then they don't feel as hungry, they're not getting enough nutrition still, so they can get trapped in this cycle. And people can enter at different points. So you might have other people who have cirrhosis and chronic kidney disease, and they have other challenges for maintaining muscle mass. So it's a complicated cycle, but the take home point is really that people can come in at different areas and exhibit similar traits. Now so we'll come back to that model, but there's a second major one that we should talk about called the deficit accumulation model. And this is that the more that individuals have wrong with them, the more likely they are to be frail. And so this was developed by Ken Rockwood, who's a researcher in Canada. And he has, this is an example of a patient, and he developed something called the Frailty Index, where we can look at the number of quote unquote deficits people have over a certain number of domains and get this number called the Frailty Index. So this is just a sort of pictorial of that. You would get a number from 0 to 1. 1 would be the most frail, and we can then stratify people based on different levels of frailty. So this is, again, this is something we use more in the geriatric consult or assessment clinic. So I wanted to just share it, but it's a little bit less relevant for our talk today. So let's go back to the primary care clinic. So should we screen for frailty? The answer to this question is still a little bit unclear. There have been some suggestions that people who are over 70, and especially those who are losing weight unintentionally, should be screened. So I think, and all of us in primary care have patients who have this sort of quote failure to thrive syndrome, and those are the patients where it does seem to be really worthwhile to screen. So people who are, especially struggling with unintentional weight loss. And I think in terms of practical frailty screening for the primary care clinic, I always like to point out several options. You guys already mentioned 2 of them. So that's the clinical frailty scale, and then the frail scale. So the frail scale is an adaptation of that phenotype model where we had the 5 different domains, and it gives you a way to ask each of those domains either subjectively from the patient or to get it from the medical record. So this is a very practical one to use in the clinic. I use this a lot in primary care because you can get, weights over time. You can get illnesses because those are typically charted in the EHR. And then these 3 top domains are subjective questions that you can ask of the patient. And again, you use the same thing where people have 3 or more, they're considered frail. I also really like the clinical frailty scale. This is also from Ken Rockwood's group. And this gives you, it has a pictorial, and then it also is primarily based on function. So if you're already getting a functional status assessment, you can really quickly do a quick clinical frailty scale score. So these 2 I really like for the primary care setting. So I want to turn to management because I'm already running short on time. So if we think about frailty as a spectrum, so from robust all the way to what's called, some people would call terminal or end-stage frailty, there's a variety of different interventions that can help with frailty management or mitigation along the way. For the people who live out in the community are typically those who have sort of mild to moderate frailty on average. So I want to point out that exercise is consistently across the board a good intervention to help with either prevent or manage frailty. As you can see, a lot of our other geriatric evaluation and management programs on the outpatient and inpatient side have also been shown to be very helpful. This is just, again, sort of highlighting that exercise is one of our most strongly evidence-based interventions for frailty. And in terms of the details of that, if you do have a patient who's already frail, they may not be able to meet minimum activity levels because of fatigue and disability. So it's always the adage to start low and go slow, and geriatrics also applies here. We want to also really focus on balance and resistance training 2 to 3 days a week. So beyond just walking, we need to do dedicated balance and resistance exercises. This is a slide with some practical resources for exercise programs that meet these qualifications, and I'm happy to share these after the presentation as well, so you have them. I will say this screenshot is from Up to Date, so they had a really great section on this, and they had some videos and pictures there. And then finally, so my sort of personal interest is on mind-body therapies, and we know that Tai Chi is effective for frailty, and so my work has been to look at yoga and looking at clinical trials that have reported on frailty outcomes. So that was the sort of my recent systematic review was looking at 33 yoga trials, and it seems that yoga and Tai Chi both are particularly helpful for frailty markers like gait speed and chair stands. So this is sort of gives your patient some broader options if they don't enjoy some of the other types of gym-based or center-based exercise. These are also some really good options. So I think I will probably stop there because we're right at 3:45. And this is an evaluation slide, and then I'm also very happy to answer any questions or comments.
Thanks so much for your talk. If anyone has questions, you can put them in the chat or feel free to unmute. That would be fine too. Oh, thanks, Amy, for putting the article.
Oh, thank you. How often should frailty screening be done? That is a great question. So there are really no clear guidelines on that. So the frequency we have adopted in our outpatient spaces has been about once a year, or if patients undergo a significant functional status change. So, but it is a great question. We don't have a lot of information on longitudinal frailty assessment in the outpatient setting.
And Dr. Braun, you have your hand up.
Yes, thank you so much. I did want to ask and sort of comment that, frailty towards what end? I guess I noticed the American College of Surgeons actually includes a frailty evaluation as part of their preoperative evaluation. So I guess I would say, that's one kind of special outcome toward which we want to assess frailty. But I mean, do you have a comment at all about preoperative evaluation and also, frailty assessment toward placement, frailty assessment toward, whatever?
Yeah, it's a great question. So, I mean, I think frailty assessment in the preoperative setting is probably considered more considered to be cost effective and valuable. So, we do it on a standard basis for hip fracture because it improves outcomes. TAVR, a lot of cardiology centers are doing them before things like pacemakers or ICD placements. So there's sort of a wide, trauma surgery, colorectal surgery. So there's a wide literature on how important that is, and especially the concept of prehabilitation. So working on different areas of vulnerability before people undergo a stressor event. So that's I would say that's a very well established, and that area is only growing. In terms of the primary care setting, if you're not undergoing a preoperative, an outcoming stressor like a preoperative evaluation or chemotherapy or something, so the focus of this presentation here is on actually how do you manage the primary frailty syndrome even when you're not facing like an imminent stress. And so that's where the value of things like exercise, nutritional diets like the Mediterranean diet or protein supplementation really come into play. So that, I think it's definitely a growing area of research. And so we'll hopefully see more to come in the coming years.
There is one question in the chat from Heather, wondering if there are newer terms being used in the place of failure to thrive.
Yeah, Kate can probably help me with this a little too. My understanding is, failure to thrive is a diagnosis in pediatrics, but not in geriatrics. So failure to thrive should prompt you to create a differential diagnosis for whatever's going on with that patient. And, if it's unintentional weight loss, maybe it's hyperthyroidism or a medication side effect or food access, or, probably in geriatrics, it's multifactorial. So primary frailty syndrome is part of that. So it could be on your list, but it's really not an accepted definition to my knowledge. And Kate, I don't know if you have other comments about that.
Yeah, so there's some controversy in the use of the term failure to thrive, but obviously all of you have heard it used and it's still commonly used. But it's kind of accepted amongst most geriatricians that it's not the best term to use because it's assuming that someone's not meeting, in pediatrics, you're not meeting your milestones. And then in older adults, that's not the case. So it's better to be describing what you're actually seeing, whether it's frailty or weight loss or frequent falls. Some people use the term inanition sometimes instead of failure to thrive to describe someone who might be like extremely fatigued, losing weight, not doing well in a lot of different domains. But I'd say it's better to just describe what you're seeing and what's going on rather than label as failure to thrive, because I also think that there's a lot of bias and some interspersed ageism that comes in when you label someone as failure to thrive. So we're trying to move away from
Yeah,
that.
and premature diagnostic closure, so early closure, which, you know, can lead to diagnostic errors. Yeah.
Absolutely. Any other questions? We probably have time for one more question. Great. Well, thank you again for this fantastic talk and for answering all of our questions. You're welcome to stay on for the case discussion, but if you cannot stay on, I just want to thank you before we move on to the case.
Thank you all.